I'll be talking about measures of association. We would have all read this. We would have all heard this. We would have used it. But let us understand what exactly it is. Okay. So when I say measures of, association, it's always, when I say association, there are always two groups or more than two groups where I'm trying to associate it with the outcome. There are several measures which we can use for measures of association. First thing is difference in means. Prajita was showing the difference between age in mean age of those who are having DM and those who did not have DM. Just a difference comes difference in proportion. One group has 40%, the other group has 60%. The difference is 20%. Then comes something called relative risk, prevalence ratio, and odds ratios. We'll talk about these things, and also we'll try to understand when to use what. Okay. The focus of this lecture is what is measure of association. It is not just giving the p-value. It is giving how big is this association and also when to use what. So let us revisit the lecture by Dr. Kalai Selvi last week, where she took you through different study designs, right? One of the classic study design, we'll start with a cohort study. Whenever we have a cohort study, we always start with what? I want responses quick. If you want to finish this lecture quick, I want your responses. We always, whenever we think of a cohort study, we move from exposure to outcome, right? Say, for example, they conducted a cohort study to see whether there is any difference in use of tobacco and developing diabetes over 5 years. Okay. So they constructed this table after the end of 5 years. What it is giving, what they are able to measure in terms of summary statistics, in terms of proportion, in those who are using tobacco and those who are not using tobacco, what they will be able to measure. What is being measured? It is incidence. Excellent. So among those who are using tobacco, what percentage developed diabetes over 5 years? And in what percentage of those who are not using tobacco developed diabetes over 5 years? Say, for example, what is the incidence among those who are using tobacco? It is 200 out of 1,000, right? 20% developed diabetes. What is it among those who are not using tobacco? It is 450 out of 9,000. So 5%. What is the difference in incidence? What is the difference in incidence between those who are using tobacco and those who are not using tobacco? 15%. Perfect. 15% is the difference in incidence. This 15% can be anything, right? It can be 15% to 30%, 20% to 35%. It can be anything. It doesn't really give you the exact relative higher risk among those who are using tobacco compared to those who are not using tobacco. If I want to calculate that, what we calculate is relative risk. Relative risk. Incidence is risk. Okay. It's relative risk. The risk among those who are using tobacco compared to those who are not using tobacco. How big is the incidence among those who are using tobacco when compared to those who are not using tobacco? How big is this? How many times? 20% is how many times of 5%? It is 4 times. That is your relative risk. That is your relative risk. In case, if both had 20%, those who are using tobacco and those who are not using tobacco, then what would have been the relative risk? It would have been 1, which means when there is no difference in terms of incidence between those who have been exposed and those who are not have been exposed, the relative risk will be 1. When there is no difference, it is 1. What is that? That is nothing but the null value. When there is no difference, the difference between the proportion will be 0 and the relative risk will be 1. If both have 20%, 20%, 20%, 20% minus 20% will be 0. That is the risk difference. Whereas relative risk, 20% divided by 20% will be 1. Please understand this concept. This goes back to what Arun sir was trying to discuss on hazard ratio. Let us keep it there. Okay. Now, how will we interpret this? As I already mentioned, risk ratio of 1. That means there is no difference between exposure group and the non-exposure group. If the relative risk is more than 1, what does it mean? The exposure group, for example, 4, the exposure group has 4 times higher risk of developing diabetes compared to those who are not using tobacco over 5 years of time period. Very important. Every point is important. The time period is important. Compared to whom is different important. How many times is important. Okay. When it's more than 1, it means they have greater risk of developing the outcome. If it is less than 1, it is basically they have lesser risk or it is protective. For example, those who have used vaccine, those who have received vaccine, those who did not receive vaccine. Those who received vaccine should have ideally lower incidence of the outcome of interest. So automatically when you calculate a relative risk, it will be lower than 1. It will be lesser than 1. Okay. Okay. Now, can someone tell me whether relative risk as such, the 4 what I calculated, is it summary statistics or a inferential statistics? The relative risk what I calculated now, is it a inferential statistics or a summary statistics? Hello? Dr. Anbarasan says summary statistics. Dr. Anbarasan, can you unmute and tell me why? Dr. Nityapraya says inferential. I'll come to you also. Dr. Anbarasan, can you unmute and tell me why?
Sir, because it is compared within the group only. It is not comparing outside the group.
It is
That
between
is
2 groups, that is exposed and non-exposed, but it is within the sample.
sample.
We are
Yeah,
not
that's
trying to extrapolate it to the whole of the population of tobacco users and no tobacco users. Okay. This
yes,
10,000
sir.
what I've studied is basically a sample. It's not the whole population, right? That is a reason it is summary statistics. What I need to calculate in case if I want to get a inferential statistics for this relative risk, what I can calculate?
Odds ratio.
No, it is a relative risk. What I can
Okay.
calculate for this relative risk? Relative risk is a measure of association. In case if I want to extrapolate it to the whole population, what I can calculate for this relative risk? I
Confidence
can
interval.
calculate confidence interval, 95% confidence interval. Okay. So again, let us look into this. Say the same example. I'll calculate a relative risk. Okay. And the confidence interval is 3.4 to 4.7. What does it mean? What would be the p-value? Can someone tell me what would be the p-value? What would be the p-value? Whether it will be less than 0.05 or more than 0.05. Less or more? Less than 0.05 or more than 0.05? Just looking at it, the 95% confidence interval, uh, can you tell that definitely those who are using tobacco use will have higher risk of diabetes compared to those who are not using? Can you tell that? Can you tell? How? lowest value is positive, or it's positive or something which is not below the 0. The null value is, what is the null value in relative risk? If both the groups are having the same incidence, what will be the relative risk? It will be 1. So 3.4 to 4.7 does not include 1. It means what? In my sample, the relative risk is 4. I am 95% confident that in the whole population, the risk, those who are using tobacco will have 3.4 times to 4.7 times higher risk of developing diabetes when compared to those who are not using tobacco. I'm not sitting on the fence here. I'm pretty sure that I'm 95% confident that it will be higher. It can be as low as 3.4 or as high as 4.7. Just understand the interplay of these things. Okay. If at all the relative risk was 0.8 to 4.7, then what will happen? I am 95% confident that it can be the chance of those who are using tobacco developing diabetes over 5 years, maybe 0.8 times that of those who are not using tobacco, or as high as 4.7 times. What I am not sure there, sometimes it can be protective, sometimes it can be as high as 4.7 times. It can be greater risk. So I'll not be able to conclude whether it is protective or greater risk. So whenever your confidence interval includes a null value of 1, that means what? I am not able to decisively tell whether it's higher risk or protective. Okay. That is when your p-value will not be significant. If the null value is included in the confidence interval, your p-value can never be significant. So if you give your confidence interval, you really no need to give the p-value sometimes. By looking at the confidence interval, we can understand whether it is significantly associated or not significant. Okay. So this is the advantage of giving a confidence interval for your measure of association. Is that okay? Most of the times when you are using cohort studies, you use relative risk. Don't use odds ratio when you are running a cohort study. Okay, it's always relative risk. The advantage of conducting a cohort study is you will be able to exactly measure the risk. Then if you are going back and calculating the odds ratio, it doesn't make sense. But when you have a case control study where you start with cases, and also you get a controls for that cases. You start with these 100 individuals, 100 diabetes, 100 no diabetes. Then what you do? You go back and see how many of these 100 had exposure to tobacco, that is those who are diabetic, and those who are no diabetic, how many were exposed to tobacco. So what percentage were exposed to tobacco among those who are deceased? 40%. What percentage in those who are non-diabetic? It is 25%. But I'll not calculate the percentage here. I'll calculate something called odds. Odds is a ratio. What I'll calculate is odds of exposure. That is odds of using tobacco among those who are diabetes. What is the odds? 40 by 60. It is not 40 by 100. It is those who are using tobacco divided by those who are not using tobacco. Those who are exposed divided by those who are not exposed among deceased, that is diabetes here. And among those who are not non-diabetics, non-deceased, those who are exposed divided by not exposed, 25 by 75. Then you go for a calculation. Again, just odds ratio is a summary statistics. When you add a confidence interval to it, it becomes a inferential statistics. By just looking at this odds ratio and confidence interval, can someone describe this to me? What does it mean? Just unmute and tell. What does it mean? this odds ratio of 2. What does this odds ratio of 2 mean? It just means those who are having diabetes have 2 times higher odds of exposure to tobacco when compared to those who are non-diabetic. Again, what is the null value here? If odds of exposure in diabetes and odds of exposure in no diabetes were equal, say 2 by 3 by 2 by 3, what would have been the odds ratio? It would be exactly 1. It would be exactly 1. Okay. But what we have here, the odds of exposure is higher in deceased when compared to non-deceased. How big is this? 2 times in sample. And I'm 95% confident that in the population of diabetes, the odds of exposure to tobacco may be 1.1 times to 3.7 times higher when compared to those who are non-diabetic. And by just looking at this confidence interval, I'm pretty sure the odds of exposure to tobacco is definitely higher in those who are diabetic compared to non-diabetic. Is that okay? Because it does not include the null value. Okay, let us move to the next one. So we saw quad study, we saw case control study. Now we are jumping to cross-sectional analytical study. This is just, we are collecting both exposure and the outcome at the same point of time. Let us take this. We are collecting whether someone is using tobacco, and also we are assessing whether they are diabetic. Okay. So what I'll get here in this, what is this measure? What measure I'll get? Incidence or a prevalence? What we get is prevalence. Excellent. So we get a prevalence of diabetes among those who are using tobacco, and we'll get a prevalence of diabetes among those who are not using tobacco. What we can calculate is prevalence ratio. Mathematically, it will be same as relative risk. Okay. But how will you interpret this 4, prevalence ratio of 4? There I was telling, in terms of cohort study, those who are using tobacco have 4 times higher risk of developing diabetes over 5 years when compared to those who are not using tobacco. But here the interpretation is totally different. It's not about developing. It's about having co-prevalence. It's about having. So what does it mean? Those who are using tobacco have 4 times higher risk of having diabetes when compared to those who are not using tobacco. Please understand this. If you are conducting a cross-sectional studies, always think of prevalence and prevalence ratios. And the interpretation of prevalence ratios is not about developing disease. It's about having disease along with the exposure of interest. Okay. And again, you can calculate a confidence interval for the same thing. And never go for odds ratio calculation if you are conducting a cross-sectional studies. Go for prevalence ratios. They are far, far better because your odds ratios will overestimate the association, whereas prevalence ratios will give you better measure. And also it's very easy to explain the prevalence ratio over odds ratios. In the past, people used to calculate left and right odds ratios because all the statistical packages were able to calculate only odds ratios. Now with newer packages, it's very easy to calculate these prevalence ratios. So please ask for prevalence ratios if you are conducting a cross-sectional analytical studies. Okay. So very simple.
Sir,
If
sir,
it's a
please come again, sir. At
okay, what exactly
prevalence ratio and odds ratio difference.
what happens with the prevalence ratio is simple. It's a common sense, right? 20% of the tobacco users have diabetes, whereas 5% of those who are not using tobacco have diabetes. By looking at this, okay, what I calculate, prevalence of diabetes among those who don't have tobacco use divided by prevalence of diabetes among those who are not using tobacco. That is my prevalence ratio. Instead, if I go for calculation of Odds ratio, what I will calculate? Odds of diabetes among tobacco users, that is 200 by 800. Odds of diabetes among those who are not using tobacco, 450 by 8550. And then I try to get the odds of disease among exposed and odds of disease among non-exposed. Why you want to do all those things when the easiest measure is to tell in terms of how big is the prevalence among those who are using tobacco when compared to those who are not using tobacco? It is 4 times. Why I need to talk in terms of odds?
No.
Why I need to talk in terms of odds? That is one simple way of describing or explaining it. Second thing is, what odds ratios does is, odds ratios overestimate the association. For example, for the same example, same number, if I calculate the odds ratio will come as 4.8, whereas my prevalence ratio was 4. Odds
What
ratio
is
always
difference between
overestimates.
relative risk and prevalence ratio, sir?
It's mathematically same, but it's about interpreting it. If I say, if for the same example, what I would have seen, relative risk I calculate only in cohort studies. What is relative risk? It's all about developing the disease. What is prevalence ratio? It's about having the disease. For example, relative risk of 4. How will I explain it? Those who are using tobacco have 4 times higher risk of developing. Please underline that word, developing, over 5 years when compared to those who are not using tobacco. When it comes to prevalence ratio, how I will tell? Those who are using tobacco have 4 times higher risk of having. Underline that word, having. Mathematically, how it is calculated, both are same. But what study design it is, that is how I interpret this. Is that clear?
Yes.
Okay, one is about, when I say prevalence, it's all about having. When I say incidence and try to calculate the relative risk, it's all about developing. Okay, mathematically both are same. It's all row percentages, what you get. Okay. So I'll stop it here. Then there is something called effect modification. In case there may be a third variable which can modify the effect, and there may be also confounding with many variables. To adjust to this, you go for a regression. I'll not talk about it, but I want to talk about one thing, that is clinical significance over statistical significance. Please note this. Okay, you conduct a study with a large sample size, and you find, say for example, you conduct a study on blood pressure, systolic blood pressure, effect of uh, physical activity on systolic blood pressure. Okay, you conduct a study with a large sample size, and what you find is there was a 2 millimeter Hg reduction in blood pressure prior to, after physical structured physical activity. Okay, it reduced by 2 millimeter Hg blood pressure, and the confidence interval is 1 to 3, and the p-value is definitely less than 0.05. As a clinician, what you need to decide is whether this 2 millimeter Hg reduction is important or not. For example, if you're applying it at a population level, it may be important. But for patients who are known hypertensives, and if it just reduces by 2 millimeter Hg, whether it is worth this intervention, as a clinician, you need to decide. For example, case 2, it reduces by 30 millimeter Hg. Okay. And it may be as low as 20, it may be as high as 40, and p-value is less than 0.05. As a clinician, I think you will be very much impressed with this intervention because it is reducing by 30 millimeter Hg. Okay. And you will be very confident to use this. The first one, case 1, you may not really impressed in using this because it's not a major gain. It is statistically significant. P-value is significant. Confidence interval is one-sided. It is 1 to 3. But the problem is whether this change is that big to take it as an intervention. I don't think so. Case 2, yes, I'll take it. Statistically, it's also fine. Clinically, also fine. What about case 3? What about case 3? If someone presents this, whether you will take it or not? Say the cutoff for considering something to be useful is 10 millimeter Hg reduction. I may not take it because your confidence interval is just 2 to 58. Okay. Case 4, I'll not even look into it because the change is also small and it is not significant because I know that the difference in mean systolic blood pressure, it may be as low as -1 to as high as 3. That means it can increase also, it can decrease also. I'm not sure about it. So I'll not take it. Case 5, the same thing. The change is small, statistically also not significant. Case 6, again 30 -2 to 62. What I'll rethink about case 6 is I will think whether if I increase the sample size and check it again, whether it changes. It may be just a play of sample size. See, one of the thing is if you increase the sample size, everything will become significant. Okay, that doesn't mean that it will be clinically important. For example, case 1, it is significant, everything is fine. But whether you will adopt it in your clinical practice, you may not, just because it is not clinically significant. 2 millimeter reduction may not be clinically significant. So always think of clinical significance over statistical significance. Okay, so that is one thing I want you to look at. That's it. I mean, it's more of a snapshot what we wanted to give about measures of association. I stop it here because it helps you to understand all the other things like hazard ratios and everything better if you have a good understanding of this measure of association and confidence intervals of these measures of association.